Everybody, welcome back. We're going to go ahead and get started for the day. Just a few reminders. Don't forget to go ahead and sign on if you're a nurse on the sign-in page. That's what we're going to need. And then don't forget to do your final evaluations because you need to get those done in order to complete everything. So other than that, there's really not a lot. Please give us your suggestions for what you'd like us to cover next year. I think that's probably it. I'm going to go ahead and turn the conference over to Brenda. She's going to go ahead and introduce our first speaker. And you guys have a good day. Welcome.
Good morning. I'm Brenda Gonzalez. I'm so thrilled to be with you all here on the second day of the Amazing Newborn Conference. This conference has always been near and dear to me in my time at UNM. I have the pleasure of announcing our first speaker, Dr. Francesca Sevy Gurule. Dr. Gurule is a native New Mexican and alumni of the UNM School of Medicine class of 2014. She completed residency at the UCSF affiliated Santa Rosa Family Medicine Residency in 2017 and completed a 2-year fellowship in maternal and child health at UNM. She joined the faculty for the UNM Department of Family and Community Medicine in 2019, where she is core faculty for the residency program, assistant director for the Maternal Child Health Fellowship, and a medical clinician in the Milagro Clinic, which cares for pregnant women with substance use disorder from all over the state. Welcome this morning, Dr. Gurule.
Hi, good morning. Thank you for having me. I am going to share my screen here. Please let me know if you're not seeing the right thing, but I hope that you all are. I'm really excited to be talking to all of you today. And I'm actually going to be focusing on pregnant and postpartum patients. So a little bit of a change from newborns, but a topic that very much affects newborns and many of the newborns in our hospital, in our state, and in the US. So as Brenda mentioned, my name is Sevy Gurule. I'm one of the UNM Milagro providers, maternal and child health faculty, and an assistant professor in family and community medicine. I'm also a Las Vegas native. I'm from, or a New Mexico native. I'm from Las Vegas, New Mexico. I went to West Las Vegas High School, so proud Don. And like many people, I have family members who suffer from substance use. So this is a topic that is near and dear to my heart. We have lots of objectives to get through, and I promise you we will get through all the ones on this list. I want to start with a definition. I think that's important. So opiate use, which is mostly what I'll be talking about, is characterized by tolerance, cravings, the inability to control use and continue use despite adverse consequences. So like losing a relationship, a marriage, a job, money, housing. It's chronic, so that's really important word there. It's chronic, so it can come and go. There will be relapses, and it's treatable, and it can be managed successfully by combining medications with behavioral therapy and recovery support. Substance use in New Mexico in particular, we have the 15th highest drug overdose rate in the US. New Mexico's drug overdose death rate is 26 per 100,000, which is higher than the US rate. Some of this data is a little bit old. I couldn't find newer data. And then 2 in 3 of drug overdose deaths do involve an opioid. And 1 New Mexican dies every 18 hours from a drug overdose. This problem costs New Mexico $890 million, and that's kind of taking into account many factors, including medical care and loss of wages. And substance use in pregnancy is also an enormous issue. So it affects about, or 8.3% of women drink alcohol when they're pregnant. 6% use illicit drugs, 10% smoke cigarettes. women are at the highest risk of developing a substance use disorder when they're between the ages of 18 to 29, which is right in the midst of their childbearing ages. And women with substance use disorder have a very high rate of unintended pregnancies. It's quoted to be about 80%. And so the general population is about 50%. So most pregnancies are not necessarily planned, but this is especially higher in women with substance use. And there's certainly risks associated with substance use in pregnancy. They participate less in prenatal care. They may come later or have fewer visits. It actually may disrupt their treatment and their substance use. So they are in a methadone clinic or they have a buprenorphine provider, and they're actually cut off from their access to their treatment because now they're pregnant and the provider is concerned about that. And maybe there's medical legal risks because they aren't necessarily trained to do it. And so they cut them off from their treatment. Higher rates of sexually transmitted infections, hepatitis C, which can go on to affect our newborns. They have worse obstetric outcomes, so higher rates of preterm delivery, preeclampsia, growth restriction, abruption. Higher rates of untreated psychiatric disorders and poor nutrition. So lots of things that will go on to affect the fetus and then eventually the newborn. Particularly growth restriction, there are concerns for neurodevelopment, opioid withdrawal, difficulties feeding, birth defects, particularly with alcohol and cocaine, not necessarily with opioids, and then fetal death. There, thankfully, are lots of ways that we can intervene with substance use in pregnancy or substance use in general. And there's the SBIRT model, which is from the Institutes of Medicine, and it's an evidence-based way of getting people to change risky health behaviors. And so screen, a brief intervention, and then refer to treatment. And I like to add prevention here because that is always, key and the most important part of intervening is if we can prevent before a problem becomes an issue. There's a couple of ways that we can prevent this issue, and it's making sure that people have access to birth control. If you are methadone or buprenorphine provider, just making sure that you're having a little checklist for women of reproductive age and making sure that they have access to birth control if they want it. Again, the unintended pregnancy rate is 80% in this population, and so really trying to intervene with birth control whenever we can. And then for women who do want to get pregnant, making sure that they're on opioid replacement therapy before they even get pregnant. And so having access to that, and that takes a lot of changes, especially in our state where there are not a lot of opportunities to get treatment. There's also prevention even further upstream, combating poverty, ensuring safe neighborhoods, judicious prescribing of opioids, treating mental illness, supporting parents and youth, and of course, preventing adverse childhood events, which as you all know, as pediatric providers, is really critical for a variety of things. But for those of you who don't know, adverse childhood events, like being in a household where there's intimate partner violence, parents who are incarcerated, have mental illness, use substances themselves, these children in these homes are 5 times more likely to go on and have a substance use disorder. And boys in particularly are astronomically higher, 46 times more likely to develop a substance use disorder. So this prevention can really start, with kids. So screening. The American College of Obstetrics and Gynecologists recommend that all women, not just the ones that you suspect, are screened for a substance use disorder. And so this is really important because, many women you may not suspect have a diagnosis, and if you don't ask, they will never be forthcoming with that information. There are several ways that we can screen. Often people will think of a urine test or urine drug test. And yes, that is one method for screening, but really we should be focusing on an interview, just straight up asking the questions, or we can use different tools like the 4Ps or the NIDA screen. These are evidence-based tools that we can use. Oh, sorry about that. to identify substance use. So the 4 Ps are, did your parents have a substance use problem, your partner? Have you in the past had a substance use problem, or do you currently have a substance use problem? And then the NIDA screen, you can see below, it kind of quantifies that by how often people are using, and then it goes through different substances that people might use. So you can include this in a checklist or something that the patient can fill out when they get there. And as you can imagine, there's benefits. You know, we can identify these people and refer them to treatment, but there's also barriers. And so there's many reasons that women do not want to be forthcoming with this information. There's stigma. They're worried that, you know, you might think less of them because they have a pregnancy and they're also using these harmful substances. And there's also legal ramifications, and that's a really big one. And while there's always a place for legal and criminal consequences, substance use in pregnancy is not the time for that. These women will not be forthcoming with their information if there's legal ramifications or if they could go to jail for it. And then therefore they're not going to get the treatment that they need because they cannot be honest with their providers. And so this really is the time to report women for this. Another important thing to remember is that people can be parents, or they can parent despite substance use. And so really taking all of that into consideration when we're involving, you know, child welfare and things. So pregnancy may be just the motivation that a woman needs to seek treatment. And so really utilizing this opportunity and, you know, maybe these like maternal instincts or something, and taking advantage of that to be able to help these women get the treatment that they need, or these pregnant patients. So brief intervention, which is really not, you know, this doesn't need to come from a OB or a midwife or any provider. It can be anyone, any of our nurses, people in the emergency department who are seeing these women for maybe a UTI, or you know, police officers who are responding to incidents. Anyone can really have a brief intervention here. The Institute of Medicine, when they came up with SBIRT, they actually said that these were for steps that, you know, community people can take. And so it's not specific to provider. And then the final thing is to refer to treatment. And so I'll be spending some time, most of the time, kind of talking about the treatment options for pregnant patients. So most commonly, we use methadone and buprenorphine, and there's pros and cons to each of them. Methadone has no ceiling effect. So women, if they are not comfortable on their dose, you can just keep going up and up and up and up on that dose, as long as, you know, their heart will tolerate, their mentation will tolerate. Methadone can only be dispensed at methadone clinics. So there's a lot of structure, a lot of supervision. Many patients will start with daily visits, so daily dosing. And there's cons, daily dosing being on both of those lists, because it relies on, you know, having access to a working vehicle, time, childcare, a flexible job, things with which many of us do not often have or have access to. And so it can really impede a woman's ability to get stable on her methadone dose. It's only available at methadone clinics. There are not very many in the state. And so that's really important to keep in mind if you are working at UNM and the woman is driving from somewhere else in the state. It may prolong the QTC interval, and so it's not safe for all patients with cardiac conditions or who are on prolonging QTC medications. And it can take weeks, maybe even months, to find a comfortable dose. So we often start at a very low dose and go up by just 5 or 10 milligrams every few days. And so women may need to continue to use when they're starting their methadone, because they're not comfortable from kind of a cravings or a withdrawal standpoint. And then there's buprenorphine, Suboxone or Subutex are other names that it goes by. It's more accessible, and so you can find it in a lot of clinics and primary care clinics. There's less overdose risk, And some of the cons are that you have to enter withdrawal, and it could be an uncomfortable amount of time that you're in withdrawal that is required before you can start this medication safely because it's a partial agonist. And there is a ceiling effect. So when you get to about 24 milligrams, it doesn't really work well with higher doses. And so if a woman is not comfortable at a max dose, really the next option is methadone. And there's rare reports of hepatic dysfunction. So for women who have underlying liver disease, that's something to consider. Neonatal opioid withdrawal can happen with either of these. So that is really important to remember, because sometimes women want to make a decision solely based on what would be safer for the baby. And really, either of them would be fine options. We just need to find the one that works. Methadone has been around longer, and so there's a lot more safety data over a longer period of time when it comes to babies. However, buprenorphine we think might lead to a little bit less withdrawal. However, that still relies on a woman being very stable on her buprenorphine and not having ongoing relapses. And so really just finding the one that works for someone. I always recommend that women start with buprenorphine and then move to methadone if it doesn't work, because you can't really go from methadone to buprenorphine, again, because you have to be in withdrawal in order to start the buprenorphine, and it can take a long amount of time to experience significant enough withdrawal to start from methadone to buprenorphine, and that prolonged period of withdrawal is not really safe for the pregnancy. Buprenorphine, only about 5% of people or physicians have a license to treat this. However, with newer legislation, the ability to prescribe buprenorphine is becoming a lot more accessible. There's mono product, meaning just buprenorphine, or buprenorphine and naloxone, which is like Suboxone. And before we used to say that Subutex was the only thing that was safe in pregnancy, but now we really know that Suboxone is perfectly fine, perfectly safe for the pregnancy, and has lower risk of diversion and abuse. And so you will see a lot more of our patients now are on Suboxone, and it's because we're making this shift, which is taking a lot of kind of education, because we've told women for so long that Subutex is the only safe option, but really we don't believe that to be the truth anymore. Here, most women are on sublingual buprenorphine, so something that they dissolve under their tongue, either a film or a pill. However, there's also injectable buprenorphine, which we were involved in a big trial at UNM, and then implantable buprenorphine, so kind of like a Nexplanon or the little birth control implant that kind of goes just briefly under the, or superficially under the skin, and then delivers some medication. I have not found that to be covered by insurances, but it could be an option for some people. We start them a little bit differently. So methadone, we're going to have them sign a contract and an agreement. We're going to discuss from that very moment that they're taking this step into treatment, the risk of neonatal opiate withdrawal, because we do not want women to be surprised. And it's actually quite shocking how many women think that their babies will not experience withdrawal on methadone or buprenorphine. So that conversation has to happen. We always check an EKG to make sure that their QTC interval will tolerate methadone. We make sure that they live somewhere near a methadone clinic before starting on it. And then we start on a low dose as long as they're not sedated. They don't really need to meet any criteria from a withdrawal standpoint to start it. And then we increase that dose very slowly over a period of days to weeks to even months. And many women, like I had mentioned, will continue to use an illicit substance in the meantime, because they don't feel comfortable on the measly little doses that we start. And so women tend to need higher doses. So let's say they were on 80 milligrams before they got pregnant. They may need a higher dose in their pregnancy because of those changes in metabolism just in the time of they're pregnant, and then they can return to their pre-pregnancy dose after birth. Buprenorphine, same thing. We talk about the risk of NOWS. We check their liver function. If they're pre-viable, we can actually start this medication safely in clinic whenever their COWS score, their withdrawal score, suggests that they're in a moderate amount of withdrawal. So a COWS score of about 10 to 12. If they're viable, however, there are risks of being in that moderate amount of withdrawal. So we actually admit these women to the hospital or have them in triage. That way we can follow the amniotic fluid levels. We can put them on a non-stress test or kind of a fetal heart rate monitor to make sure that their fetus is tolerating this withdrawal, so that we can get them into a significant enough withdrawal to be able to safely start the buprenorphine. And then we can titrate the dose over a period of hours to like a day or two. And so we really can get them onto their comfortable dose very quickly. I just want to say a little word about fentanyl, because it's actually changing the way that we are doing buprenorphine and methadone very significantly, very drastically. And you may have seen this for those of you who are treating babies with neonatal opioid withdrawal, that many more women are on methadone. And we think that's a variety of reasons, but one of the biggest reasons that we see this, or we think that we are seeing this, is because of fentanyl. So fentanyl which is kind of outlined by this, I guess it's like a yellowish line here, is one of our synthetic opioids, and it is on the rise. It is rapidly increasing in our state and in other states across the US. And even though we think of fentanyl as a very rapid on, rapid off medication within your system, we found that women who are using fentanyl on a daily basis, either mixed in their heroin or primarily fentanyl, actually metabolize it very slowly. They have delayed renal clearance, and so it sticks around in their system for a long time. And even though women feel that they are withdrawing and they are in a moderate amount of withdrawal and need it to start buprenorphine, they actually need to be in a much more significant amount of withdrawal than we previously were able to dose buprenorphine because of this poor renal clearance of the fentanyl. And so we're more likely to precipitate a worse withdrawal or make them much more sick, even though we were starting at a COWS score of 10 to 12 that we previously used, because this fentanyl is just super tricky. And so it is making it really difficult to start buprenorphine. The other thing it is doing is that even women who are on max doses of buprenorphine are not feeling comfort or feeling the relief that they previously felt on these medications, because the fentanyl is just so hard to, I guess, overcome. And so we do have a lot more women who are choosing to go the methadone route because of this. And so it's really, really changing the way we practice. It's really kind of making a lot of things more complicated that we didn't necessarily anticipate. I can see questions popping up in the chat, but I can't actually see the chat.
I'm happy to read them to you, Dr. Gurule.
Okay,
Sonia do you want to wait until the end or right now?
It seemed like they all kind of popped up with this fentanyl question. Is maybe I could just take a couple now. Yeah, let's do that.
Sonia wants to know, is there a correlation between the intensity of NOWs and which substance between methadone and buprenorphine the newborn is withdrawing from? So basically, do newborns have a greater chance of withdrawing if their mothers are on methadone or buprenorphine?
Yeah, so we think that buprenorphine has a little bit less likelihood to need treatment for withdrawal. That being said, we have patients on both buprenorphine and methadone who need their babies need to be treated withdrawal. I have women who have been incredibly stable on their buprenorphine. Their babies have needed to be treated withdrawal. So it is not a foolproof answer to say that either of them are without risk, but buprenorphine may be slightly less. The more important thing is that they have been stable on their dose or their medication for a significant amount of time before they give birth, because we think that it's those babies who are having lots of kind of in utero withdrawal because of like their heroin or fentanyl use that they're kind of using on a daily basis, or they're getting onto bupe, relapsing, getting onto bupe, relapsing. And so they have a lot of in utero withdrawal. That really is at higher risk of then having withdrawn in the newborn period.
Thank you. The next question is, does when a mother start buprenorphine or methadone in pregnancy affect the chances of NOWS?
Yes,
Oh,
I kind of mentioned that, but the sooner that they are on it, the more stable they're going to be throughout their pregnancy, and they're not going to be having these peaks and valleys and kind of with chronic withdrawal in utero. And so if they can be on it preconception or since the beginning of their pregnancy, that's going to improve their chances. But again, I still see those women and those patients have babies who need to be treated for withdrawal, so it's not foolproof.
I think it's also so important for us to remember that these women need to be stable during their pregnancy because they're at such a high risk of preterm delivery, miscarriage, stillbirth, and death, their own death. So I have one more question.
Okay.
Are people on buprenorphine or methadone for the rest of their lives, or do they wean off at some point?
Yeah, that's an excellent question. So we really should be thinking of buprenorphine and fentanyl, or buprenorphine and methadone as medications for a chronic illness, like we would, insulin or a beta blocker for someone with diabetes or heart disease. And so if they need to be on these medications for the rest of their life, they can be. However, like insulin and a beta blocker, if they can make changes and find that, the social support and the lifestyle changes and the support in their everyday life that they feel like they can come off of these medications, they could. And so really it's up to the woman and what she wants to do with her medications. But if she wanted to be on them for lifelong, that would be fine. We do recommend that they stay on these medications for at least 1 year postpartum, and I'll get into that a little bit later on why that's important.
Thank you.
Great. I will keep going and then we can have some more time for questions at the end. So really I spent a lot of time on methadone and buprenorphine because we can't impact or have an effect on the other areas of their treatment if they're not comfortable. And so that really is the foundation of their recovery. And so it is not abstinence. It is not weaning their medication. It is being comfortable on a medication-assisted therapy that is really the evidence-based way of treating substance use. And then from there, we can go on to build on their treatment, which is also very important and very necessary. And that's, assuring their safety, treating their mental illness. Many pregnant patients have a dual diagnosis of a substance use disorder and a mental illness. And so making sure to tackle both of those issues and then planning for relapse, because as I mentioned, it's a chronic disease and relapse should be expected. That way, if we expect it, then we have prepared for it. And then at the very kind of top of that, this treatment for them is their prenatal care. And so we try to get all of their, many people will try to get their prenatal care kind of taken care of, but we can't do that if they're not safe and comfortable and thinking clearly. And then even beyond that are all these other kind of areas that we can focus on, treating their partners, because if their spouses and their boyfriends or their girlfriends are not also stable in their recovery, that makes relapse even more risky. Getting them housing, doing more ultrasound monitoring, and these are higher risk pregnancies. And so keeping track of those things throughout the pregnancy as well. I think and this is just maybe a plug for what we do at Milagro, but I think it's really important to coordinate prenatal care and substance use treatment. This in general is a population that's already hard to make one appointment, much less, multiple appointments with your substance use provider and your prenatal care provider, who don't necessarily know how those two things interact or interconnect. And they're more likely to be compliant. Maybe the pregnancy is really, really important and they want to come to their prenatal care. And the fact that they can also get buprenorphine there is just kind of a plus, or vice versa. They don't have great, they're not really excited for this pregnancy, but they do want to get into their recovery. And so being able to kind of mesh those two complicated pieces of their healthcare is really important. And so again, just to shout out for what we do at Milagro and family medicine, which mostly does a lot of the Milagro work, because we're able to provide that and then continue to follow them postpartum as well as a lot of the babies. And then I want to talk a little bit about treating these women at the time of delivery. So a lot of the stuff I've mentioned is really in regards to prenatal care and getting them stable while they're in the midst of their pregnancy. But sometimes we don't see women until the time of delivery. And so there's other things to really consider at that point. It is really important that we are treating women and treating their pain. Delivery is an incredibly painful time. And this particular population, they might also be experiencing, withdrawal and a lot of things that will make it more complicated. And so we really need to treat their pain. And there's a few kind of notes that I just want to say about that. They may need higher doses. And it's not that they are, drug seeking by any means. They just have a tolerance that is built up to opioid medication. And so they do need higher doses to achieve an adequate amount of pain relief. Do not stop their buprenorphine or their methadone. I have heard in other parts of the state that a lot of anesthesiologists think, well, buprenorphine partially, antagonizes the receptor. We need to stop it. That way we can then give them medication. And that is actually not the case. There's no evidence to suggest that that they can't just treat as they would, but again, with higher doses. So it's really, really critical part of treating their pain is to just leave them on their regular medications. And same thing with the methadone, continuing that on top with regular medications that you would use in that situation. Those medications are not adequate enough to treat pain relief. And so, still giving them oxycodone or hydrocodone or fentanyl or whatever medications you would be using in general on top of those is really important. And then thinking and being creative about non-opioid analgesia, like, in a postpartum or a post-operative C-section patient, adding gabapentin, ibuprofen, Tylenol, all of those other things that can also help combat the pain. We also need to treat compassionately. Some providers and nurses and other people on this call may not be equipped at the end to provide buprenorphine, but we are all equipped to treat compassionately. And so it's really, really important that we recognize that birth in general can be a really traumatic time in a pregnant person's life. 1/3 of women will describe their birth as traumatic. 1/3 of that third will go on to have diagnosable PTSD disorder because of their birth experience. And so we really need to be mindful of that, and knowing that a lot of these women also have a history of trauma, sexual abuse, intimate partner violence, a lot of risk factors that make the birth experience even more risky of being traumatic and unpleasant. And so knowing the signs of trauma can be really helpful to take a step back and just kind of make sure that everyone on the team, from the labor and delivery team to the nurses that are taking care of the babies afterwards, recognize these signs of trauma and treat compassionately. And so women may be anxious or agitated or irritable, and all of these are signs of trauma. They may be having, difficulties kind of concentrating, and we're trying to get them to push, and they really can't even, focus on pushing. And so it's really important that in this particular setting that we're being mindful of all of that. It's important that we ask women permission to touch them, to enter their room, to remove their gown. I can't tell you how many times I've been on labor and delivery, and we just, undress women quickly because we need to, put an ultrasound on her belly or something, and it's not the most tactful way of doing things. And so always trying to ask for permission when we can, and it's safe to do so. We need to create calm spaces, safe spaces, both physically, but also emotionally. So, you know, when these women come to labor and delivery, when they're sitting in the NICU or the intermediate care nursery, they really do hear everything that everyone is saying around them. And so making sure that we're also just providing them in a safe emotional space is important. Taking the time to discuss why we're doing what we're doing and the risks and benefits of the different options, being respectful with informed consent, but also refusal. And sometimes it may take longer to get to the outcome that we're looking for, but when it's safe to do so, again, just allowing for that space and that time. Prioritize continuity. So whenever we are taking care of these women in the postpartum floor, in the NICU, anywhere, having the same nurse and the same faces can really help build this trust. So that's also really important. And then doulas, which we have a volunteer doula program at UNM available particularly for women who have a substance use diagnosis, can be really helpful and empowering. And then treating withdrawal. So they are now admitted to the hospital where they may not have access to the substance that they were using before they came to us. And they just gave birth, and it's a stressful, emotional, exhausting time. And so we really need to treat their withdrawal. It is very complicated to treat both pain and withdrawal. So if they come in the door and they're in labor, maybe they're just in early labor, but they ask for something for pain. Once we give them a fentanyl or the morphine through an epidural, we've kind of lost or prolonged our option for starting buprenorphine. And so maybe doing the buprenorphine start first and just kind of planning accordingly if it's appropriate. And then, I mean, just, you know, imagining if any of you have given birth, kind of that physical and emotional toll that birth is, and then, you know, adding on top of that withdrawal and just this, you know, how we just need to approach it with, you know, the utmost compassion and love. And then postpartum, we really need to focus on all the things we would on a postpartum but also a lot of other things. And, you know, that's making sure that at that point, they're getting to continue their MAT treatment, contraception, you know, treating their hepatitis C. That way, you know, they're not at risk for vertical transmission with their next pregnancy, you know, doing all of these really critical things postpartum, where we often kind of drop the ball in this, you know, fourth trimester of care. This population is incredibly vulnerable to postpartum depression. And so making sure that we're following them closely in that postpartum state to make sure that we're treating postpartum depression appropriately. And then overdose prevention is really important because that the postpartum state is a high risk time for overdose. This table is actually the maternal mortality rate over the last few years, and it's on the rise in the USA compared to other, you know, developed countries. And I couldn't find specific data to kind of like break out all of the different numbers, but I found a Colorado study, so our neighbors, that had maternal mortality data broken up into the cause of it, and they 15 to 30% of those were related to either a suicide or overdose postpartum, and I think probably a lot of them are overdose. We've actually had a couple here in New Mexico, and so maybe even more than a couple, but that I'm aware of in my own patient population. And so really making sure that all of these women are going home with a Narcan prescription is life-saving. There can't be enough Narcan in people's homes and in the community. And again, you know, a lot of time especially in our incarcerated patients. Once they are no longer pregnant, the jail or the prison no longer has an obligation or really a desire to continue these women on their buprenorphine and their methadone. And then many of them are go on to be released. They're not on their life-saving MAT therapies, and they do overdose when they leave jail because now they have lost, any amount of tolerance that they had previously built up. And so that population, the incarcerated patients, is especially at risk. And it's very unfortunate because it's like, well, while you're with child, we're going to treat you, but when you are no longer with child, we don't really care about your recovery. And so we're just going to stop these medications. It's a really very sad thing. And so continuing methadone and buprenorphine at least 1 year postpartum as, overdose prevention is also important. So as I mentioned earlier, I have a lot of roles and a lot of hats, but another role that I have is also just being a new mother. And I gave birth about a year ago and have probably my own pregnancy and birth has contributed greatly to my ability to care for my patients, but more so than my own pregnancy and birth is also just my own postpartum course. And I am probably among the most privileged mothers to have ever given birth, being a prenatal care provider, having a lot of information about breastfeeding, having friends that I can text, at any time, day or night, doctors on, my son's doctor, my doctor, are my friends, so I can also ask them questions. I have an amazing husband who's also a nurse and in the medical field, and in-laws and parents and sisters who can all be available to help me. And still, it was like the most exhausting and exasperating time being a new postpartum mom. And so often we're asking these women who do not have any degree of family support, who do not have any social support, who don't have, health literacy or any education, breastfeeding knowledge, any information to like, okay, here you go, welcome to the world. You have a new baby and you have a substance use diagnosis and you're trying to navigate your recovery. And maybe all of these risk factors for why you have a substance use diagnosis, like your own poor parenting from your parents and poor coping skills because of your parents, and all of these things have created this like very how are these women going to succeed, when it's hard for me as the most privileged mom to succeed. And so in this postpartum phase, just, really finding it in yourself to be, to give the utmost kind of grace and respect and love for the situation that these patients are finding themselves in, because it is a rough time in a parent's life. And so, and it's especially rough when you don't have anyone there by your side. So what can we do as providers moving forward? We can screen, because once we've screened it, we can identify it and move on to the next steps. Refer to treatment. You can be a buprenorphine prescriber if you are able to do that, or you could judiciously prescribe opioids so people do not go on to have a problem that stemmed from the healthcare system. We can recognize that substance use is very complicated and probably started, or that path started from when they were, a 5-year-old in your primary care practice. We can recognize the importance of trauma-informed care, be compassionate, treat mental illness, treat partners, lots and lots of things that we can do. And as a community, we can go even further to tackle the problems that that can be the starting point of a substance use diagnosis. So treating homelessness, we can also not treat substance use as a criminal issue, but really as a healthcare issue, and making sure that people are having access to medical treatment and not just jail and prison. We can continue to prioritize policies that improve access to treatment, especially in our state, which is a huge state with lots of deserts for access to treatment, even worse for access to treatment when you're pregnant. And then inpatient treatment facilities and investing in our youth. There's a few resources, SAMHSA, which is kind of a lot of information about buprenorphine. They also have specific information for buprenorphine in pregnancy. And then at any time, if you live in New Mexico, you can call PALS line. We have a Malagra provider on 24/7 available to answer questions, especially if you do want to treat pregnant women, or if you want to get her into the Malagra clinic. We can absolutely help you through the PALS line. Thank you. I see some more questions in the chat. I don't know.
There are some questions piling up. The first is, what is the wait time to get into programs in Albuquerque?
Well, interestingly, if you're pregnant, there isn't a wait time, which is, really incredible, but also just kind of says a lot about how we don't prioritize other things. But if you want to get into a methadone clinic at ASAP, they will accept you within a few days if you're pregnant. If you want to get into the Milagro clinic, we can often see you in a week or two.
Thank you.
That's another reason it's really important to initiate this care in pregnancy, because once you have your spot in your methadone clinic, you're great. If you are postpartum, it is harder to find a clinic. They don't have these spots for postpartum women that they do for pregnancy. And so it may take a little bit longer, weeks to a month, to get a spot in a methadone clinic.
Thank you. The next question is, can you speak about best practices for treating those moms who are not interested in a treatment program after delivery? Is it harmful to start them on buprenorphine knowing their likelihood is low of continuing? What type of pain meds do you give to hold off withdrawals?
Yeah. So if often, women may not kind of know exactly what they want to do postpartum, or they may be saying, I'm just going to do this while I'm pregnant. But that's like their initiation of their care. And so that we're barely building that foundation and that trust and getting them more familiar with their treatment. And so they may change their mind later. So I would still absolutely start it. And if they don't, that's also in their prerogative. And with good informed consent, they can also stop it later on. So that's absolutely fine. And then to treat their withdrawal, I would use buprenorphine or methadone, because ideally then we can get them onto those medications at that point. If they don't want to be on buprenorphine or methadone, it's a little bit more complicated to treat their withdrawal, because we can't use like oxycodone or hydrocodone in the hospital to treat their withdrawal. I will say that I have women, or I've seen patients that don't necessarily want to be on buprenorphine or methadone, but they will in the acute phase in the hospital, just to find some relief and comfort.
Thank you. The next question is, it's more of a statement. It says, Judy Sweeney wants to encourage providers to refer to a home visiting program in your community for support for the pregnant women and for the first few years, such as Firstborn for first-time moms and Avenues Early.
Absolutely, yeah. And I think Dr. Pratt-Chavis will spend more time on the next talk.
Victor has a question. Given the legal challenges, as you mentioned, is there any reporting system in New Mexico so we can have decent data on substance abuse in pregnant women and nows? Important in terms of prevention success of programs.
So we are supposed to be reporting nows with our kind of hospital data, and so we can keep track of how many of those babies are being treated. I've heard there's a lot of issues, particularly if babies do not end up getting treated. It may not necessarily be like well reflected within their discharge summary that they were at least observed and monitored, and that data is just as important as if they were treated. So that is a reportable diagnosis. So it should be happening. I don't think that it does just because of documenting issues and stuff, but it should be happening. And then the other thing that should be happening for all of these dyads is CARA and CAPTA plans as well. And so ideally that happens at the time of birth and discharge so that they can continue to follow them and provide resources to the mom and baby dyad.
Okay, Yvonne wants to know if a mom is a polysubstance user, is it recommended or okay for them to breastfeed? If not, is this discussed with them prior to delivery at a prenatal visit?
Yeah, that's a complicated question, and it first relies on which substances and then if they can achieve recovery. And so Milagro, particularly with methamphetamines, cocaine, and marijuana, or actually I'll just break those two up. So methamphetamines and cocaine, we do tell them in their prenatal care period, these are contraindications to breastfeeding. If you really want to breastfeed, we recommend starting to quit since now, because when we see those newborns, we do rely on those biologic screens, so urine drug screens, to determine if mom was in had enough long enough cessation from methamphetamines and cocaine before she can breastfeed. So those particular ones, yes, they need to stop. Yes, we talk about it in the prenatal care period. No, not necessarily compatible with breastfeeding. That being said, sometimes we will make treatment plans for women and their babies if they seem motivated to breastfeed, and can follow up, and we'll continue to provide urine drug screens. It takes motivated providers and good follow-up care to do that. And then for marijuana, we also talk about that in the prenatal care period and the implications in breastfeeding. And marijuana is not a contraindication to breastfeeding, but women who do use on a daily basis, who use heavily, need to be counseled on the risks of breastfeeding marijuana use. And so we try to have that conversation, and then again, informed consent. But, you know, if those happen in the prenatal care period, it's way more effective than kind of springing this information on them at the time of birth and delivery, because they may not have had the option to kind of quit sooner.
Judy had a follow-up comment. She's the one who was speaking about the home visiting programs, that there are also childhood services, and we can just Google home visiting programs. They support mom and instruct on development.
Thank you.
And another question was, has COVID affected rates and support available to these moms?
Yeah, I think the same support and infrastructure exists. I think it seems our numbers have decreased a little bit. Maybe COVID, maybe fentanyl. Also just like their own social networks and familial networks is probably less, but a lot of the programs are still, you know, in place to offer these services. Methadone clinics have made a lot of changes because they didn't necessarily want patients going in on a daily basis. And so sometimes they're giving 2 or 3 days of medication at a time. There's also some pros with that, I would say. But, you know, there's not as much in-person support and counseling that is happening. And so, you know, it has changed things, but programs still exist and they have adapted.
I think that's all the questions, Dr. Gurule. I just wanted to really thank you. That was such a informative program or presentation. And I especially, you know, I'm a NICU provider, and as a lot of the folks here are pediatric or neonatal providers, it's so important for us to remember that the compassionate care that you spoke of must follow these babies. You know, we need to treat their families with respect. Personally, I believe that nobody wants to grow up to be a drug addict. It's just something that they've fallen into because of the circumstances in their life. And it's such a pivotal time for change, this pregnancy. And I appreciate you pointing that out to us. Thank you so much for your presentation today.
Yeah, of course. Happy to be here. Thank you.